So more than remembering like how much the values are here in the intermediate risk, your goal should be if we are starting statins, how much reduction we need to go for. So if we are starting statins, at least remember this one that LDL should like our goal is keeping the LDL less than 10. Okay. Apolipoproteins, I we hardly do it. It's the generic whatever thing. So it usually is recommended by our cardiologist, so it's very less likely in the daily basis someone is doing it. But yeah, in the exam, if they're giving you, you never know. So it should be less than 0.8. Okay. So risk factors for the screening for the dyslipidemia, in which one you are going to do. So as I told you, the age factor is usually more than 40. I was saying 30. Sorry, we go for more than 30, 40. I mean, in my practice, we are going for 30. See how big difference is for the screening. But yeah, so usually for the bookish knowledge, men's and women ages more than 40, then we start the screening for dyslipidemia, like giving them lipid profile. Then the increased incident in the indigenous individuals or the individuals of the South Asian ancestry, then current cigarette smoking, type 2 diabetes, high blood pressure, then the family history of the premature CVD, family history of dyslipidemia, erectile dysfunction, chronic kidney disease, inflammatory disease, HIV disease, COPD, and then incident of atherosclerosis. So you can see whatever it's there, it's making sense. All you need to remember is the one most important thing is if they are 40 plus, and if they actually, even in 30s, if there's someone from the South Asia, like from Pakistan, India, or whatever from there, or indigenous, in those cases, we do start in 30s too, like early age too. Okay. So then we can see at this is a full lipid profile in every 3 years, as you can see, and females more than 40 who are menopausal or at the age of the where you can think that there is additional risk of that one. So FRS supposed to be done every 5 years. Okay, although we do it every year, but FRS scores to be supposed to be done every 5 year, and the lipid profile should be done every 1 to 3 years. So don't mix up. FRS is a calculator, we put every formula things over there and they calculate it. This lipid profile is basically a blood test. We do calculate or check the cholesterol from here, put it in that calculator, and FRS calculates for us how much there is a heart condition or how much there is a chances of atherosclerosis or heart attack in upcoming year. If tomorrow I could recall, I will go and take a picture of that FRS calculator and send it to you guys for your idea how it works. It's very easy and straightforward, so you don't need to go into very detail of FRS. Okay. So then history and physical examination, lipid profile, TLC, and all of those ones tests we do, apolipoprotein, urine, then hypothyroidism, CKD, diabetes mellitus, nephrotic, and then liver disease. Non-fasting with the fasting, non-fasting is basically can be used for the Frankman risk score, and then fasted and not fasted does not, I mean, does not make sense, but yeah, here we do practice the fasting one. So non-fasting LDL has the same prognostic value as the fasting one. So you can see non-fasting and fasting does not make any difference. Recently, like I think today, someone asking me what's the difference between non-fasting and fasting. I said in the bookish knowledge there isn't much difference, but in the practice wise we do see it much difference when we are calculating the hard risk score. So you can see from here non-fasting can be used for the Frankman risk score. Then risk strategy, all of those ones we are looking for completed for the man and woman for 40 to 75 every 3 to 5 years. Then we are checking for the heart age. So simple is that. Then more important thing is other targets and all of that one. So you can read this one just for your this thing. Then comes the management. Health behavior, obviously smoking cessation, dietary modification, physical exercise, and then lifestyle modification at least 3 months before considering the drug therapy. So you can tell them if because some people usually they present with fatty liver, so in that cases you can tell them this thing that third 3 month if they do the lifestyle modification they might get back to normal, or if they start losing their fat and then help them to weight loss and all that. Then pharmacological statins, what are the main risk factors? So myalgias, rhabdomyolysis, like telling them they might have a body fatigue and pain in the body. In that cases you have to come back and we will see what is going on. That's where side effects ezetimibe can be used up to 19% of those ones. So if there are severe myalgias, rhabdomyolysis, so usually we stop the statin and switch on to something else. Now, the monitoring is important for the statin. Before starting the statin, usually we go for ALT, CK, creatinine, checking for their kidneys, the muscle mass like creatinine kinase, and then ALT, their liver. So as you can see, kidneys, liver, and then muscle mass at as baseline between 6 weeks later for the signs of transaminitis and myositis. Tolerate risk in the CK up to 10 times upper limit of normal versus 2 times, 3 times. So in that case, you have to see how much was the CK and how much it increased after starting that one. So that's why you have to follow up again in 6 weeks. Then the serum creatinine rise up to less than 25%. No routine. So usually once we check it before starting that, checking it, then starting the statin, then checking it again. Then once it got stabilized, like some people do come, oh, uh, uh, I have muscle pain and I'm taking statin for 5 years. So now they're already taking it for 5 years. It's hardly or less likely that they are having this muscle pain from that one, but it's no uh, it's no harm to checking that this statin is not causing any problem. Okay. So no routine assessment or measurements if adequate response and the lipid profile every 6 to 12 months where you are have started the statins. Okay. Then you can see this one here, the metabolic syndrome. This is very, very important. The straightforward diagnosis can be asked. The central obesity, with the high waist circumference, with the triglycerides high, HDL high, BP high, fasting glucose level high. So in that cases, if there are either two of them along with obesity, like anything, BP high, glucose high, along with obesity, this is basically metabolic syndrome. Straightforward MCQs can be come from here and ask you what is this one. Okay. Then exercise, you can see how much exercise is good for which person. So usually it's more than 30 minutes. For toddler, it's more than 180 minutes. For preschooler, it's more than 180 minutes. And for the children, more than 60 minutes and 150 time. So the main important thing is the screen time. How much screen time is good for the toddlers or preschool, because they are kind of something they do like to do. So you can see no more than 1 hour of the screen time is good for any of the individuals, either infant, either toddler, either preschooler, or even children in school. So for adults, it goes up to 2 years, but not more than 2 years. Okay. So for your understanding. Then comes the smoking cessation. In this one, you need to remember the doses, or sorry, the drugs, not the doses, sorry about that. So the drug which is helpful for controlling of the smoking. So usually we do start with pre-contamination, contamination, all of that usually works. And then educating about where the withdrawal starts, how you're going to control that one. Then counseling session works together, then willing to stop, how you're going to start with nicotine replacement. And then nicotine replacement is one of the best choice for the pregnant patient. So please keep it in your head. If someone is not willing to stop smoking, in that case you can offer them the nicotine replacement therapies. um, then the nicotine replacement therapy is one of the best choice. Then what are the other ones? Bupropion, Verniclean. Verniclean is best for that one because it helps with the craving. So usually we do give the Champix. I have given a lot people Champix. Okay. Then the types of the nicotine replacement, what are those ones? Gum, patch, inhaler, and the spray. So all works very good. The inhaler and spray causes cough because we take it through that way. Patch causes irritation, and then gum causes a lot of the gum sores and all of that. Okay. Then on the sidebar here, this one is mainly important for the what it says Nagoski. Set the quit date, tell family, anticipate challenges, and then remove the tobacco products. 2 to 3 onset of the withdrawal is 2 to 3. Peak withdrawal is 2 to 3 day, and then improvement starts 2 to 3 week, and resolution is 2 to 3 month, and high relapse is also 2 to 3 months. Then we are talking about bupropion and then vernicline. You can see which one is best. Bupropion has a seizure, eating, and all of those ones, and then vernicline is best for the craving one. Then unwilling to motivate. This is just for quick reading. If something can be asked, so you have understand how what you are writing down or what to choose. So Unwilling to quit, motivation intervention, so relevance, risk, reward, roadblocks, and repetition checking for whatever it is. Then the recent quitter is basically high relapse within 3 months. So in that case, you have to check for those ones. Then comes the alcohol use. As I was talking about in psychiatry, if you could recall that I was talking about the drugs. So in those drugs, they are the same kind of things. Okay, so it can present with intoxication and it can present in the simple daily family practice. So because in our daily family practice, like how I am doing right now, so patient can be coming and be like, oh, I am doing a lot of alcohol and then I'm having withdrawal, and we do give them diazepam, like 2 to 3 tablets as needed. Okay, not a lot of them. This is for their alcohol seizures. But at the same time, if someone is like, I want to quit alcohol and I'm looking for something that can help me with that, in that case, is the diazepam is not the choice. So you need to see which one is that one. So in that case, we either go for a comprosate, that's also or something else that they have done like research about, like naltrexone or anything that they are looking for. So you can see now a patient is coming to you in two different forms, what they are looking for or what they ask in the exam. The choice is different. So please look into that and then make your own notes. That's why I said, when you're doing a quick revision, they are too much for you to, like, you cannot keep on reading all of this again and again, again and again, because this is not that is important. The important thing is the drugs, which drug is for which problem. Okay, so you can see the alcohol use, you can go for cage asking about drugs, drinks, how much they take, how much is affecting their life, is they having depression, is they having using a. So whenever you're talking about alcohol, always keep in your head, you have to rule out the smoking, you have to rule out the drugs, and you have to rule out depression as well. Okay? So psychiatric choice. Then AST, ALT, CBC, GGT, and MCV is looking for. And then we are going for the 12-step program, alcoholic one, then the specialist opinion for the psychiatrist. And then you can see for the withdrawal, it's diazepam. Withdrawal, any kind of withdrawal, seizures, a single withdrawal, and like I am having some sort of cramming, or if I feel like want to go for the alcohol, then I start feeling restless, my hands are shaky, any kind of those ones, we do give the diazepams. Okay, then the disulfiram, we don't use it anymore. Then naltrexone, it can be used and it can reduces the craving. Okay, and then comes the acamprosate, it reduces the craving as well. Now, the naltrexone and acamprosate, usually the naltrexone is basically may trigger withdrawal in the opioid one. So usually we do prefer the acamprosate because we are not sure if they're taking opioids or not. So please keep it in your head what you are doing. And then if they have given you a choice of naltrexone and acamprosate, so go for the acamprosate. So that's how you make your choice when you are choosing between the MCQs, what they are looking for. They cannot be directly asking you what are the drugs for the alcohol. No, they will ask you what are the drugs for alcohol withdrawal, what are the drugs for alcohol abuse. He's presenting to you, he's having his trouble, he just look at this, like a scenario like this. A 30-year-old male came to the clinic. He while he drink alcohol, while in that influence of the alcohol, he beat his wife or something like that. Now he's repenting on that and he's feeling bad and he wants to quit alcohol. What And he's looking for a drug. So now they gave you an idea where he has a motivation coming from somewhere and he's feeling bad about it. It means he's already at the stage where he wants to take an action. So you have to give the medicine. Which medicine? Acamprosate. You can give the acamprosate and you can see if he's having the withdrawal or whatever that one. So in that choices. This much you can like what's important, like the family medicine, that you have to thoroughly keep reading. Now when we are talking about common presenting complaint, what you need to read from here, any kind of problem that comes in the family medicine. I told you, whenever you are studying either respirology, either but like whatever it is, dermatology, whatever, just keep it in your head. This same patient, if presents in the family practice, how will you deal with that? The same patient presents in emergency medicine, how will you deal with that? Believe me, it will be so easy for you that you don't have to go separately from each and every topic. Same thing, everything is same. Like a MI patient can be present in emergency and MI patient can be present as a follow-up with a family medicine. So please keep it in your head when you are doing it, how you are going to treat that patient. So For your understanding, if you can read, what are you want to read from here, so please read the sidebars, whatever it is. The pain precedes nausea, vomiting, and cause and is most likely require surgery. What are the red flags? Because in this history, if they ask you in the family medicine practice, usually our questions are the one that help us to make the diagnosis. So if they ask you that you are a family physician, abdominal pain came to you, or a patient came with abdominal pain, she's 35-year-old female, and she is having mainly the pain vibrating from here, there, blah, 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 whatever it is. So then you can see we are talking about female, 35. Now, our choices is maybe PID, ectopic pregnancy, or whatever those ones. But if it's a male, then there is no ectopic pregnancy, there is no PID or nothing like that. We will be thinking different ways. And on the same time, what else are we looking for? The red flags, if any of the red flag is mentioned in the scenario, then our management will change. That's why the red flags are important, because on the basis of red flag, if there's no red flag, the answer will be reassurance. That's why if you know the red flags, and if you could able to find that in the scenario, you will be able to see what you are going to do next. Okay. So you can see the flags are pain, shock, signs, distension, pain out of proportion, new onset of the pain, weight loss, blood per rectum, anemia, supra clavicular nodes, and then history of the those ones. If there is more than 50, this is basically abdominal aortic aneurysm. And if once it's diagnosed, you have to keep checking through the ultrasound. Then on the basis of where the pain is, you have to do the investigation. And I think we already have an idea, if this is the right quadrant, then what's the lever is there. If it's the left quadrant, if it's the left flank, if it's the right flank, what is the problem according to that one. Okay. So if you keep reading from here, you can, like, read everything. There is nothing that you can skip. It's basically everything is the same that we already discussed. The allergic rhinitis, in this one, the management is important, because in this one we have to counsel the patient about the conservative. Then along with that, you have to start with the cetirizine like Reactane or beta-estine or whatever it is. Then allergy skin test, because we do ask or ask patient then that should we refer them to allergy specialists. So usually many do ask them. And then immunotherapy, in basically in those cases we go for the epinephrine. Then amenorrhea, anxiety. I think we already discussed how anxiety presents, then the differential diagnosis of anxiety, symptoms of anxiety. So you can read from here. This will help you to make the diagnosis. If there is a symptom of anxiety in the, so for your understanding, let's suppose you read all of the family medicine in your first read, like thoroughly and everything. In your second read, you want to read the whole family medicine, good for you, very good. But if let's suppose you want to be like, okay, I'm reading same thing over and over and it's nothing important, I don't feel like reading it, in that cases at least do the sidebars and the tables from family medicine, you are good to go. Then in the third or last read, in that case I would suggest at least do the tables, and if you have time to do the sidebars, you are good to go. And now, the last time, I would suggest going for only MCQs, especially for family medicine. Okay. So that's how you are going to do the revision over and over time. Okay. So keep it in your head. First time is the most important one. Let's suppose in the first time you are not able to get anything. It's okay. It's fine, because family Toronto notes is kind of very lengthy. In the second time, do it again. Third time, you will be able to see, okay, yeah, I understand this one is there, this one is there, and then I don't need to read it a lot. Okay. So by the second and third read, you will be able to understand this is not that crazy that I need to read it again and again. I know my points and I know like how can I deal with it. Okay. So in that cases, only you can do the sidebars and then charts. Okay. Then the symptoms of anxiety in the form of panic, it's basically either a panic come with a special occasion, in is basically patient avoiding it, then it's a panic disorder. If it's out of blue, then it's a panic attack. Okay. Then if there is any triggers, then this is basically specific phobia, like with specific thing. If it's with the surrounding, then it's a social phobia. Patient where it may be difficult to escape, this is basically agoraphobia. Then we are talking about the symptoms of the specific experience trauma. Now, if it's less than 1 month, then it is PTSD. Not PTSD. The acute stress reaction. The D means the disorder starts after long period of time, like more than 1 month, more than 6 months, more than 3 months. So if there is month, time, then it becomes the disorder. Okay, even in the panic attack, sorry, panic disorder, it has been going on for prolonged period of time. Okay, so recurrent anxious attacks, then excessive worries and apprehensions and common concerns. If it's less than 6 months plus stressor, then this is an adjustment disorder, like move somewhere, now unable to sleep and all that. If it's going for more than 6 months, now it becomes disorder. Which one? Generalized anxiety disorder. If there is no thoughts of intrusive or inappropriate as distressing, in that case is like they have, like, all those OCD symptoms, where the completion of something that they want to do. Okay, so for your understanding, I just read it again. Again, we are going to do the CBT and relaxation. Then comes the asthma and COPD. I mean, if you can do it from here, you're good enough. But if you want to do a little bit extra, then go to it from respirology. It has little bit more. Okay. I mean, if you feel like you want to make a good concepts about asthma and COPD, then you can do it from respirology. If your concepts are already good enough and you understand what is COPD and asthma and whatever the basic understanding, then this from here, it's more than enough for you. Okay. So usually the COPD and then asthma. COPD is basically that comes with the smoking history. There is an obstruction going on. Along with that, now smoking along with comes with the air pollution and occupation. It's usually present at certain, like after 60s, 30s, 40s, where he has been smoking for prolonged period of time. So they do mention smoking in COPD anyhow. Then come second-hand smoking or maybe first-hand smoking. Okay. Then comes the asthma. There is usually a trigger. They will mention some age factor, like maybe early age, less than 10 years, and all of those ones. Then in that cases, the diffusion capacity is basically decreased in COPD, but in asthma it's normal. Then signs and symptoms is chronic cough sputum. So think about emphysema in this side. So they can present with a yellow discharge, fever, and all of those ones. Then this one is wheeze, dyspnea, chest tightness, prolonged expiration, cough. With that one is mainly in the morning and nighttime. Spirometry. Now, when I'm talking about spirometry, I just want to tell you, before 5 years of the age of the child, we don't label them as asthma, because it's important to do the spirometry and make a diagnosis. So we do call it RDS in child before 5 years, but we don't call it asthma. Okay. So for your understanding, if they ask you, can you label a child before 5 years? So you cannot label it as asthma. So with the bronchodilators, it do get better. Then one of the most important thing is don't give steroid in this one, in COPD, sorry. Then the chest X-ray is often normal, or there might be in hyperinflation, CO2 or bulla formation. So in that cases, they can present with the pneumothorax too. In this one, there is an hyperinflation during the asthma attack. Management is obviously in COPD. We have to start with smoking cessation. Then we give the SABA as needed, and then SABA plus ipratropium like LAC, or the LABA, and then SABA plus LABA like short acting, long acting. That's what I'm talking about. And along with oral steroid, very less likely. It's a very less likely that we go for steroid in the COPD, because it can trigger any kind of infection. So in that cases, and then we can also give prophylactic antibiotics where you feel like there could be an infection. And most important, one of the thing, the prevention, how will you give, what are the vaccines that you will give? So please keep in your head, especially the COPD vaccines. What are those ones? Pneumococcal influenza vaccine. Then whenever you're talking about the asthma, the education is important, environmental factor is important, their family education is important. Then we are going to SABA. They keep it with them, rescue inhaler like salbutamol. Then the maintenance therapy is basically long-acting inhaled corticosteroids. That's because they are already taking SABA, so we don't start SABA. Okay, please keep it in your head that for asthma, the first step is inhaled corticosteroid, because they are already on the rescue inhaler like SABA. Okay, so then we are going to start with the ICS, and then slowly we increase the dose. Medium to high dose of ICS or the low dose of ICS plus LABA if someone is not, especially if the mother is coming to you and then mother is taking salbutamol, and then you already start the inhaled corticosteroids. Now she is not comfortable in increasing that dose. What will you do? So it can be asked. So in that cases, we either go for the long acting bronchodilators. Okay, so please keep it in your head that in that case is what you need to choose. Then the third one is going for the moderate to high dose plus LABA, and then SWARE one is basically as above and plus immunotherapy, glucocorticoids orally given, pneumococcal vaccine, and then influenza vaccine. Please keep it in your head in that every kind of the patient we do have to offer the pneumococcal and influenza vaccine, or they can be asked to which vaccines you would prefer in the patient of COPD or in the asthma. Okay, I hope this makes sense to you. This is kind of important, like, which stage you are going to start, and mother is not comfortable because asthma patients are mainly come with the in the child cases. So the mother is there, or you started an inhaled corticosteroids, and now father is having a problem. Like, why did you start it? You already discussed everything with mother. How are you going to deal with the father? So I hope this makes sense to you because this comes an ethics point of view where there is communication problem, family barriers, ethical dilemma is being challenged, your communication skills are being challenged. So you have to see in that cases how you're going to approach that. Although education is important, telling them, then educating about the asthma, how important is the inhaled corticosteroid, how important is the benefits of inhaled corticosteroid for this patient, then going for that one, and then having a family meeting or talking about together. So that's how the ethics question come. Okay. Then the BPH, again, we are going to do the investigation starting with the urine analysis, checking for that. Please, there is one thing here. Before doing the urine dipstick, DR is something that we have to mention. Okay, I know it's kind of something even in the NACOSCI. I mean, my personal experience, we do miss the DRE. DRE is a part of abdominal examination. So wherever we are talking about any kind of abdomen problem, pelvis problem, DRE is something that you have to at least keep it in your back of your head. Then urine analysis, serum PSA, then creatinine bun, PVR, ultrasound, all of those studies. Then there is obstruction, irritative, and then late complications. What are those ones? Then refer to the urologist. Usually, hardly we do anything. We just refer them. Although we do tell them about fluid restriction, avoidance of the medications like antihistamine, diuretic, decongestant, Kegel exercises, bladder training, and then alpha like antagonists which are tamsulosin. Then finasteride can be given, antimuscarinic can be given, long-acting phosphodiesterase inhibitors can be given, and desmopressin. Now again, how I read it, that's not how you need to remember. So you need to remember if we are talking about the relaxed, smooth muscle around the prostate and the bladder, if someone is having constriction at that point, and in that cases you have to give the tamsulosin. Okay, in the patients where they have a problem with DHT, in that cases we give the finasteride because it helps, or there is a problem with the enlargement that the prostate is getting enlarged. In that case we go for finasteride. In the cases where there is a bladder outlet obstruction, like he feels like going for bathroom but he's unable to pass the urine, or is unable, he has to put the strain while passing the urine. In that case you have to go for antimuscarinic. If a patient is having erectile dysfunction, in that case we have to go for long acting phosphodiesterase inhibitor. Desmopressin where there is having nocturnal polyuria. I hope that makes sense because these are the things that we'll be looking in the scenario. Okay, a patient comes to you, she's having, or he is having a lot of polyuria at night time. What are the possible tests you would like to do in this case? So usually my first thing that I would like to do is UTI. Second will be checking for the diabetes. Then third comes for this prostate. And then what are the medicine? If it's confirmed that this is BPH, this could be desmopressin. I hope that makes sense. That's how they do like to ask, like, what are you going to do? What's your differential diagnosis? And because once we are doing the differential diagnosis, or what is your first most likely diagnosis? Okay. Then absolute indications in which one we are going to go for the surgery, TURP or TUIP. So I hope you guys are understanding how we are going for the family medicine, whichever topic comes like right next to other one. Bronchitis, acute bronchitis is typically a clinical diagnosis, so we don't go for anything else. It's upper respiratory tract infection, mostly viral, resolves by itself. If Anyone start having fever, anything like that, in those cases, we go for chest x-ray, PFTs for checking for the asthma. Then the primary prevention and the secondary prevention. Primary prevention is drinking fluid, hand washing, smoking cessation. Then the symptomatic is rest, fluid, humidity, analgesics, antitussives. And if someone is having respiratory issues, in those cases, we give salbutamol. Current literature does not support any kind of antibiotics. Okay. Then the chest pain. The chest pain, all you need to read the risk factors, the red flags, the swear pain, pain more than 20, swear or consciousness, hypotension, tachycardia, bradycardia, cyanosis. MI in the elderly patient is basically can often present with dizziness, back pain, lightheadedness, and the dizziness. And in MI in diabetic patient, it does not cause any chest pain. Then ECG chest X-ray in MI, it's different, like how we go for that one. Like in MI, we go for the an ASA, aspirin basically, sorry. Then morphine, like MONA. I hope you guys know that morphine, oxygen, nitrogen, and then the nitroglycerin I'm talking about. And then A is basically aspirin or low molecular weight happening. Then the reperfusion therapy with the fibrinolytics, then start the beta blockers. Endocarditis, in that case, is giving antibiotics. GERD, in that case, is giving H2 and then NSAIDs. In that, nitroglycerins, wait for 5 minutes between the sprays into and then going for that one. So I will stop here because I wanted to do ECG in the next one so we can cover the chest pain and then we can go for the next one.